back a little bit. I pushed the other lecture, so we'll do the other one tomorrow. This is really loud. Can y'all still hear it back? Can you still hear it? Okay, I'm gonna turn it down a bit. So I wanted to start right here, and because we went over that background, took more time on the background, now a lot of this other stuff will make sense to where we don't have to take too long. Just what I want you guys to do as we start to go through these classes is to try to connect the mechanism with what we talked about in the pathophys so that you can kind of cement it in your brain as to what it's doing. If you can do that, when we get even to the next lectures, it kind of makes sense because you're going to see these same drugs several times throughout this first block, okay? So we're learning it now, and then as some of those other lectures come along, we'll be like, oh, okay, yeah, we saw this already, we saw this already, we saw this already, okay? So ultimately, with our ACE inhibitors, right, one of the ones that were in our backbone, we want to decrease our blood pressure. That is the goal, that's why we're taking the medication. In the name, you see that it is an ACE inhibitor. So we are stopping the actions of ACE, so preventing that conversion, right, to our angiotensin II, which we didn't want to happen, okay? So when you're looking at this, think about the fact that if I do that, I can decrease vasoconstriction. That is the name of the game, because if I'm like this, my blood pressure is going up. When I vasodilate, I'm open, things can flow, and I'm decreasing my blood pressure, okay? So this, we don't want. This, we're okay, all right? So your goal when you're doing your meds and you're dosing your patient is to say, all right, I want to open this to get this just right, because if I open it too much, we have all those side effects, some of the ones that we talked about where they're going to come and they're going to say, oh, I just feel tired, oh, I feel dizzy, those types of things. That's when you know, okay, let me back off a little bit and start to play with their dose, okay? So lowering the blood pressure, big thing with these, they're not doing anything with the heart, okay? They're just dealing with the resistance that we were experiencing. So remember our equation that we talked about, right? So that's how we see this lowering. It's not doing anything with that cardiac output. We're not touching it. We're not worried about that. We're worried about resistance when we're looking at our ACE inhibitor. So that's why you'll keep seeing a lot of stuff where it's saying like, I'm not dealing with the cardiac output. I'm not touching that cardiac output, because some of our other meds, we will deal with that. When we talk about like our calcium channel blockers, our beta blockers, that is going to be dealing with the cardiac output, okay? So keep the differences separate in your mind, okay? Make those stand out so that we understand our mechanisms and what we're targeting, all right? So vasodilation, reducing the retention of that sodium in the water, and then remembering that we have that increased output. We're talking about an increase in our blood pressure, the increased output in the sympathetic nervous system. So if I can block that, then I can be calm again, right? I'm not in that fight or flight mode. Everything is kind of calmed down, okay? So that's why that's important. The RAS system and our sympathetic nervous system being activated are things that we don't want when we have patients who have hypertension, okay? So our meds are typically targeting those two things in some form or fashion, okay? All right. So looking at our ACE, we were talking about this yesterday with the bradykinin, and understanding that that is what is going to give us that vasodilation, right? Which is what we want. This is a great thing for us to have, right? Hey, ACE, I don't want you to continue to break down my bradykinin. Let's leave it around for a little bit longer so that I can have more vasodilation. Let it do its thing. Also, the part with that bradykinin is that you'll see that it is a part of the formation of our nitric oxide and our prostaglandins, which help with vasodilation as well. Okay, so this is like that added benefit that you're getting when we're talking about using our ACE inhibitors. What we can see with this is that you'll have people more likely to have angioedema or have a dry cough that's associated with them using ACE inhibitors, because that bradykinin is probably a part of that pathway as well. So you'll see this more so in your African American patients, where it's like, okay, does this medication work? Yes, it works. Do we avoid it? Sometimes we try to. Instead of giving them an ACE, what was our other A? An R, right? So I can still give them that R. Depends on who you're talking to. This has been a debate that has been going on since I was in school. So that was almost 15 years ago, okay, in pharmacy school. So like, this is a thing that they're going to one day hopefully figure out. But the idea is that they think the bradykinin is less active, or we don't see as much of that sympathetic output in African Americans, and so you have more chances of them having the angioedema and the cough. Some providers discard this whole theory and they will put a patient on an ACE, even if they're African American. Certain conditions, like if we're talking about CKD, we will also sometimes see where we'll put a patient still, even if they're African American, on the ACE, and if they have that angioedema, or if they have the dry cough, we'll take them off, okay? They're also doing studies right now to see if they have less, I don't wanna say beneficial, their outcomes aren't as good, is what they're thinking, being on an ACE inhibitor versus putting them on an ARB or a calcium channel blocker or a thiazide. So for exam purposes, just understand that there is a possibility that with your African American patients, that they can respond, they have a higher chance of responding and getting that angioedema and the cough than any of your other ethnicities, okay? So more cough, angioedema, African American patients, does not preclude you from giving them this medication, okay? And then I'll give y'all, we'll talk about this a little bit more because it comes up again. Okay, so our uses, hypertension, you'll see this if somebody had MIs, you'll see this if somebody has heart failure, we'll talk about it. I mean, there's several different indications as to why we can use our ACE inhibitors, and like I said, in this block, we're gonna continue to see them come up again. So you'll see them when we talk about some of these other disease states as well. And then again, that reduced efficacy in our African American patients, just understanding that we think that it could be a possibility that they have a higher rate of mortality. It could also be contributed to the fact that if they experience that cough or the angioedema, that they don't want to be adherent to their medication, right? So there's so many different factors that can go into it, because if I'm just hacking all day, probably not gonna take my med. And if I don't go and talk to my provider, then I just stop my medication, you won't know, especially if you're not following up. So again, that 1 month follow-up that we talked about yesterday, make sure you're doing that with your patients so that you can also see if there's any side effects that they're experiencing. This side effect is not limited to just African Americans either. It's just that they're more likely to experience it, okay? So don't think that that means that nobody else can get angioedema or the dry cough, because they can't. Adverse effects, we've already talked about this. The dry cough is a big one, and then your angioedema. So these are just some pictures of kind of how patients swell up. Again, everybody can have this occur. Your African Americans are just 7 times more likely to have this occur to them, okay? So that dry cough and the angioedema, that bradykinin kind of hanging around, depending on what ends up swelling in the angioedema, you can see like her mouth is like pretty much closed, right? She is not going to be able to breathe through her mouth, or he, I don't know, I just assume. But you see how big the tongue ended up swelling. So like it can be a very, very serious thing. So let your patients know whenever you do initiate this medication, like, hey, it's not very common, not something that we see often, but if this does happen, I need you to get to the ER, okay? Tell them don't wait, it's not gonna get better, they need to go, it's gonna continue to get bigger, all right? Some more side effects that we'll see is some taste disturbances that some people will complain about, the hyperkalemia, and then the serum creatinine increase. When we look at guidelines will tell you that 20 to 30% of that serum creatinine increase within that first 4 weeks is acceptable. We expect to see it, but then it starts to taper down. That's why you are going to check in with your patient again after that first month that you initiated the medication. Because sometimes we do see this, and when people don't follow up, it can end up becoming very harmful to your patient, right? Because then you'll have them essentially with a higher serum creatinine for a very long period of time, which then starts to affect the kidneys, their clearance of other medications if they are on anything else. So it starts to snowball. So 1 month, we're checking up, but we do have some wiggle room, that 20 to 30%, to where we can allow that serum creatinine bump to occur, but we do expect for it to go back down. It should not remain that way, okay? So it's a big deal. Make sure that once you get them stable, they have that 3 to 6 month follow-up that is occurring. Okay, so it's just that algorithm that I talked about where I was telling y'all like, hey, just make sure we remember who has one, who has two, and when we're following up. If you initiate or if you change your medication, we're seeing them in the 30 days, and then after they get stable, every 3 to 6 months is where we'll kind of see, follow up with our patient to make sure that they're doing all right. Looking at our contraindication, this is going to be something that you're gonna need to make sure your patient does not have prior to you starting their medications. So stenosis is essentially like the hardening, right, of something. So when they have renal artery stenosis, that renal artery is now hardened, okay? So the vasodilation or constriction that I would typically see, it's not functioning right. So if I had that constriction and I wanted to dilate by compensating, I can't. It's difficult, it's stuck, right? So when we look at this, we're not gonna use this in our patient who's already stuck like this because we wanna maintain that renal blood flow. So we wanna constrict as much as we can to get that blood flow to continue to go through as much as possible through that narrow hose. So think about it as like essentially increasing the pressure to force it through there, because if we vasodilate, that pressure is gonna drop further in that small, if we get it vasodilated enough, because we may not be able to because of the stenosis. So we would be essentially harming the patient because their GFR would be like decreased no matter what we do, right? So we're trying to keep their pressure up to keep that flow going through the glomerulus, okay? So that's the idea behind this contraindication. And then the monitoring, which again, that month follow-up is important. We're looking at that serum creatinine, which remember we have that 20 to 30% wiggle room of how much it can go up within that first month of us using it. Their potassium, this all makes sense when we look back at our initial diagram that we went over and all of the things that are blocked, right? So we're gonna make sure that their potassium is okay, look at their BUN, and then just see what that bump looks like. And then over time, remember our effectiveness is gonna kind of go down just a little bit. We should start to see this increase in that serum creatinine go back down again, okay? So it is normal to see it. It should not remain that way, is the name of this when we're talking about the serum creatinine. Remember what you're monitoring, okay? Yes. So you get your baseline, you're not, realistically, you're not bringing anybody in, 30 days. Now, y'all are not gonna put somebody on something and be like, all right, come back in 2 weeks. You're not even gonna have a patient act, like, realistically speaking, you're not even gonna have an appointment to do that. But, yeah, 3 weeks, sorry, 3 weeks. A month is what we're gonna stick with, because in a perfect world, yes, but some people, you won't even see their full increase in that serum creatinine at that point because they haven't been on the medication long enough. So you're trying to get it to either to peak and to go back down. So that's why we give them that time per the guideline. But yeah.
She's on 2 drugs, like primary hypertension, where you choose like 2 of the 3. And is that bump in serum creatinine going to be an issue if also chose the thiazide diuretic?
It could potentially, yes.
So
the reason why you're prescribing them together, right? Let's just say I just so happen to come in for my checkup. You have no idea how long I've been riding that way. Like how long have I been riding high and what damage have I caused thus far? So, and it also depends if somebody is in the ER when you see them and they present in a hypertensive crisis or emergency. Cause then their blood pressure is even higher and you're gonna start it. Like it is a caution, but it's not like our biggest thing that we're worried about because I can hit an arrhythmia, I can stroke, I can do anything with my blood pressure being that high. So you're getting them down. By the time they come back in that month and you're reassessing, you're like, okay, do I need to pull and do one thing at a time is kind of what you're saying, right? Like put them on one so that if something is wrong, I know which one did it. Is that kind of your, yeah. But there isn't anything wrong with that, but when they're that high and you need to put them on 2 agents, that's why we'll just start the 2 agents. Most of the time, this doesn't turn into a big problem. Most of the time, it doesn't. Okay, it can, but it is a caution for us to look out for. All right, it's a safe bump. It's an expected bump. All right, pregnancy avoided. Okay, So if you have someone who has hypertension and they're on one of these meds, we're switching them to our Lifetime movie networks, right? Okay, so just remember that you're not going to leave them. This is going to be something that you can definitely catch, because a lot of times people are gonna be able to get to you to see if they're pregnant before they can get to their OB, okay? So you're going to be the one who is gonna do that medication rec, and you're gonna be like, okay, what do I have on here that someone who is pregnant cannot take? And you go through all those meds and you just start yanking things off, and you put them on something else, okay? And then when they go to their OB, you need to be like, hey, I changed this medication. They're gonna need to follow up with you, because sometimes it depends on what OB is doing. It may take a month or two before they can even get into OB, because OB wants to make sure that those levels are high enough whenever they do their labs and all that good stuff, okay? So it just depends. So make sure that you are seeing when they got their appointment with OB, because if you do start them on a medication, you still need to follow up with that pregnant woman within a month if she has not gotten to her OB yet, okay? So you can't just be like, oh, I switched her and leave her out there, because what if the dose that you put her on isn't effective, right? And her blood pressure is starting to go up anyway because she's making a little human. So you still have to follow up with her until she can get into her OB appointment, all right? Looking at interactions. These medications are great medications. They're cheap medications. They're effective medications. But most medications come with interactions, right? So when you see your potassium-sparing diuretics and your potassium supplements, just make sure that you're understanding that that can increase the potassium that they're retaining. When you do all of that, you have that increased risk of an arrhythmia, right? Which death can occur if they don't realize that they're having it, or how bad is that arrhythmia? What type of arrhythmia did they get? So we are very concerned about this, so that's why those baseline labs are very, very important. And then you just counseling your patients and letting them know, like, hey, these are potential things that could interfere with what you the new medication that we put you on. Also, make sure you check in with people about supplements and multivitamins. They don't think to tell you that, okay, because they didn't need to come to you to get it. And so a lot of people don't remember things that are over the counter. So when you ask your patients, like, hey, what meds are you taking? And then they'll tell you, or they'll give you the stuff that has prescriptions, and then you'll say, okay, anything else? And they're gonna say no. So you have to say, hey, do you ever take Tylenol? Do you ever take ibuprofen? Because NSAIDs, we have problems sometimes with some of our hypertension meds. So do you ever take any type of NSAIDs, like ibuprofen? Anything else? Do you put any Bengay on, like topical creams? Are there any multivitamins? Like, you're gonna have to start naming stuff, and they'll be like, oh yeah, I do that, I do that. You're looking at them like, I asked you, what do you take? Okay? So when you do your med recs, you'll see that. So ask those, even when you're in phase 2, like, get into the habit of that. Like, ask those questions, give them some of those examples, bless you, to where you can get their brain going, because they're also nervous that they're in front of you. And if you gave me a medication that I have to take every day for the rest of my life, I'm also probably not all the way listening to you, okay? So remember to kind of get that full med rec in, so that you know what potential could be making your medications not as effective as they could be, or harming your patient. And then the renal trifecta, so these are essentially other drugs that people, like I said, do take, and they may forget to tell you, hey, I'm taking this, all right? So you have your diuretics, your, if they're taking another ACE or ARB, remember we're doing one or the other. They should not be taking both of them together. So you pick an ACE or you pick an ARB. You're not gonna be like, oh, we're giving you both of these, okay? ACE or ARB, that's why it has the slash. It's not a combo slash, it's an or slash. Pick one. And then your NSAIDs, this, we'll look at a picture of this on the next slide, but essentially what's happening is you'll see where you have vasoconstriction at your afferent. So remember, your afferent is arriving, it's going in. So you have vasoconstriction occurring there, and then you'll see that you have a lower GFR. So if you're doing that on top of like an ACE inhibitor, you'll see that that now has additive effects. We'll see a picture on the next slide. And so essentially, you see that AKI occurring, or acute kidney injury, because now we have all of these drugs that we're taking at one time together, and the kidney is just getting, think of it as like it's a punching bag at that point. Okay, there's too many things that need to go through it, and it's just taking insult. Okay, so it ends up with an AKI. We can fix it. You remove the drug, right? We remove that offending agent. So these are the things that you're looking for. These are the meds that you're looking for that are very, very, very common when somebody is taking an ACE inhibitor. If they're doing NSAID every now and then, it's not gonna be an issue. But if I'm a person who's taking it every day, like say I have arthritis and my doctor was like, here, have some ibuprofen. And I'm taking ibuprofen like every single day, this is where you see those problems. But for somebody who's taking it like a couple times a month, like you're not worried about those people. The PRN people who are really PRN, but not like an everyday PRN, those are the people that you're worried about, okay? If they're taking this every day, then we are worried. And this is why. So you see our perfusion in the normal cell. So this is our perfusion in cell A, okay? And this is normally what we see, right? We have our afferent going in to the glomerulus, and then you have your efferent exiting, right? So afferent arriving, efferent exiting. When you have decreased perfusion, you'll see where your body starts to compensate. So this is what we would want to see, typically. So then I have some vasodilation, so therefore now I can open my water hose up and I can have more now volume going through. And then I'm gonna filter, and then I'm gonna, go out, efferent, I'm exiting. In a patient who is taking an NSAID, because we have prostaglandins help decrease like inflammation and things like that. But whenever I'm using my NSAIDs, you'll see that I have decreased, I think I said that backwards. When I'm taking an NSAID, I'm having decreased prostaglandins, okay? So therefore, you see how here, there's like constriction now. So my water hose has started to close, right? So now I can't get as much through. So ultimately, you're gonna see this GFR lower, right? Which we don't necessarily want, especially if you're thinking about one of your patients who has like stenosis and things like that. We're already gonna have a low GFR. So when you add on like an ACE or sometimes our NSAIDs, we see an increase or a further decrease in their GFR. And then here, you'll see where we're giving them that, the ACE inhibitor, right? So now I have where I'm getting more in, but I now am not gonna get as much out. So this isn't as open as it could be or what I would expect to see. So just understand that if I have my ACE here, my ACE here and my NSAID, if I were to put a plus sign here and add this together, ultimately I'm gonna see a low GFR. That's all I want you to remember from this. NSAIDs, ACE inhibitors are not good. And then looking at these three, right, a trifecta, these three are issues if I compound them together. If I am using them temporarily, because sometimes we do have to use a diuretic temporarily, just expect to see sometimes bumps in like their serum creatinine, and we call it squeezing the beans to try to diurese them to get fluid off of them, but it's not something that we leave on for a long period of time. So essentially you'll cause an AKI on the person on purpose, and then you take the agent away. So when you see that serum creatinine hit a certain number, you're like, okay, we're dry, and then you remove the agent so that their kidney function can restore, okay? But you're monitoring them, you're watching them when you're doing this, yes.
So you said that we only use the diuretic temporarily, but for stage 2, it said we used to either pick the thiazide, which was the diuretic, correct? And then the ACE or the CCB. So would you say that usually we do ACCB then instead of a diuretic? Or?
So I'll give you a question, whenever I make your practice questions, I'll try to give you one to where you can see this. So when we talk about, and I want to make this clear, I told y'all this last semester, I want to tell you that. A lot of this stuff is like, you will see the specialists do things that we tell you not to do. And I'm not kidding, like I was in my residency and I'd be like, you can't do that. And I was like, inside my head, because I'm pretty not gonna tell them that they can't do it, like out loud. And so when you look at what they, like how they know how to manipulate things and they're monitoring in a situation, you'll see a lot of the contraindications, they're like, yeah, I'm doing this for that reason. I'm causing this AKI for this reason. And then they'll explain it to you and it'll make sense. So I will show you like laid out what this looks like, and I think it's at the end of this, that we go over like what a treatment plan will look like.
Okay.
Because there's different diuretics, and I'll have it I'll show you.
Okay.
I think I wrote it out again, and I've been doing too many lectures, fixing and trying to delete slides. And we're gonna skip some slides today too, so just be ready for that. Okay, so our ARBs, right? ACE or ARB. When we're looking at our ARBs, remember all of these have sartan on the end, okay? So that's a way for you to remember them. Again, I'm not gonna make up names. I'm going to tell you, like, so just remember, if you have an ARB, it ends in sartan, okay? Don't try to, you can, if you want to, but don't try to remember all the names of the drugs. Sartan is your ending that you have for your ARBs. These are also in combination with my hydrochlorothiazide, right? So if I have somebody that I need to have on too, this is a great option for me to choose. The thing with this is we don't see that cough because we don't have the bradykinin like we had with our ACE inhibitors, right? What did our ACE inhibitors end in? Pril. Okay, so we have pril and we have sartan now. With our ACE inhibitors, we were worried about that dry cough, we were worried about the angioedema. Here, this is the benefit. We don't see that. But these are not as cost-friendly for some of your patients. So this is a conversation to have with them if they don't have insurance, if you're practicing outside, because you know here we give everybody what they need, right? But if you're on the outside, this may be an issue for somebody. If they don't like to use the pharmacy on post and they want to go off post and they're not active duty, they will have a copay. Some of these are more expensive copays than our typical like ACE inhibitor medications, okay? Because they have different tiers that we talked about last semester. So this comes into play if money is a concern for some people, okay? So just think about that whenever we're looking at that. And then when we talk about the studies, again, ACE inhibitors have been around longer than our ARBs, so that's why we have more data, but it doesn't mean that this isn't a good medication. We still use this medication, and a lot of people who can't tolerate our ACE, we end up putting them on an ARB. So you will see them, you will prescribe them, you will use them. So looking at this, what our ARB stands for is the angiotensin II receptor blocker, and it's essentially doing that. So far we have two things that we can remember their names, we know what they do, okay? Our ACE inhibitor, and now we have our ARBs. So when we're talking about blocking this receptor, just think about it not allowing that angiotensin II to cause the vasoconstriction that we would see because the receptors are blocked. So I can't get to my receptor. I can't do my action on that target, okay? So this is a blocker, ARB blocker, okay? And then when you're looking at this, you see that aldosterone secretion is also reduced, so therefore we think about increasing our secretion of the sodium in the water, right? So now I'm gonna urinate all of that out. I'm not gonna reabsorb it, okay? So that goes back to when we were talking about our RAS system. Remember, all of this stuff keeps just tying back to the very beginning. So if you understand the very beginning that we took forever to go over yesterday, this is now gonna help you remember all of your mechanisms so that it can kind of click in together. And then looking at your clinical use, again, these are not, they are a first-line medication, so I don't want you to think that they're not a first-line medication, but we prefer our ACEs over our ARBs. We typically start with our ACEs over our ARBs, okay? Again, we'll go over it where there are certain conditions where we will choose an ARB first, especially if somebody has experienced angioedema sometimes before, or they have a history of it. Oh, there's a dead roach. I thought it was moving. I just saw something out the corner of my eye. I was about to leave y'all. I hate roaches. Just thinking about the clinical use of them, just understand again what we're talking about. We're talking about hypertension, so we want to lower that blood pressure. You have some of the benefits that we see with our cardiovascular benefits of our ACE inhibitors. Those are still there. So that's why you're typically picking one over the other. Big benefit is that lack of the effect on the bradykinin, which then decreases us, avoids us from having that dry cough or the angioedema. Adverse effects. So you see here the lower risk because of the bradykinin that we already talked about. Just thinking about your pregnancy again, we're avoiding it. We already said that with our ACE inhibitors, so we have this with our ARBs, right? Like keeping the train going so that it's easy for you to remember. Not gonna get into the details, but just understand that like it can cause them to abort their child. both of these meds can. So that is very important, like that stop and that intervention that you will have is gonna be very important. And it's more likely to happen earlier on in their pregnancy than later, so you're gonna play a huge role with that. Looking at this, you'll see that hyperkalemia, so this looks almost like what? Our ACE inhibitors that we just talked about, right? Just with a decreased risk of the cough and the angioedema. So you look at one, you're kind of learning the other one. Same exact interactions, this trifecta is still here, and then we're not using them together because you'll just see that you'll have an increased risk of side effects, increased risk of hyperkalemia, which is not going to help anyone, so that's why we don't use them together. Remember one, and you're okay, just the big difference between the two is where they're acting. One is acting on the ACE, one is acting on the receptors for your angiotensin II, and then your ARB is also having a less incidence of a cough or the angioedema, okay? That's the big difference between these two drug classes, okay? All right, calcium channel blockers. So we kind of touched on them a little bit. You have your dihydropyridines, or you'll see this abbreviated as DHP. And then you have your non-dihydropyridines, or you'll see non, and then they'll write DHP, okay? So remember DHP, because a lot of people will put this in their notes. So when you think about this in your endings, I'm trying to help you remember them. So your dihydropyridines, or your DHP, and NPs, okay? So amlodipine, felodipine, nicardipine, nifedipine, okay, P. When we look at this, your DHPs have more of an effect on your pressure, so peen pressure, like your blood pressure. Whereas when you're looking at your non-DHPs, these have a lot more effect on the heart. They're more selective for the heart. So that's why in our chart when we were going through the very beginning, you saw calcium channel blockers in 2 spots. Don't look, because I'm about to flip really quick so I can show y'all what I'm talking about. So this is where we were talking about that previously, right? So we see our number 5, we had it on the heart, and we had it on our vasculature, essentially. So I told you to write on the one that's on the heart, that's your non-DHP, okay? Because your DHPs are not necessarily going to affect your heart. They are more so focused on your vasculature, okay? All right, don't look at me, come back. All right, so that is what we were talking about in the very beginning, the difference between DHP, which in peen, they're more focused on your pressure, whereas your non-DHPs, you have 2, Verap and Dilt. And that's the easy way for you to just try to remember it. Verapamil and diltiazem are your 2 meds that go over there on that side, okay? These are very good also for some of your patients. We'll use, like if a patient can't tolerate a beta blocker, we may put a patient on a non-DHP because again, we still get the effect on the heart that we want. But there's several different contraindications that we're going to talk about as to why some people can't use a beta blocker. So we'll say, oh, okay, cool, let's put them on a non-DHP calcium channel blocker, okay? So you have to make sure that it is your non-DHP. So remember your 2 that don't end in P are your verapamil and your Dilt, okay? All right. When we're looking at our mechanism, just essentially thinking about, again, the name is telling you what it does, okay? So it is a calcium channel blocker. So it's blocking that inward calcium channel, or I think it's the L-type calcium channel, okay? So therefore, we're allowing some of that, that heart or the contraction to kind of calm down. All right, because I don't have the calcium in there to make my squeeze as good. So I'm blocking that. So if I have less calcium, think about calcium as making something strong, okay? So if I'm blocking that from coming in, it's not gonna be as forceful, okay? And then you see that you have the vasodilation as well. So therefore I have my, my decrease in that vascular resistance. So you see how this is all gonna lead to us having a lower blood pressure, right? Going back to our equation. This hit almost every keyword that we had in our equation, right? So we're dealing with the cardiac output now, and now we're also dealing with the resistance. We're getting very good effects from this medication. And then the categories that I talked to you about already, so your DHP versus your non-DHP. When you look at your DHP, just don't ever think that you're using these for a cardiac benefit, okay? Always think non-DHPs when we're talking about anything that has to do with their cardiac, like with the heart, okay? And then you see that those, again, all in impedance, so those are just your the tricks that I gave you. Now, with these, depending on the dose and depending on that patient's sensitivity to the medication, you can sometimes see reflex tachycardia. So that heart rate will drop, and the body is like, wait a minute, we're typically up here, and you just dropped me down here. So it'll have a reflex, and it'll go back up. Sometimes this goes away, and they'll just it feels like a little palpitation, and then they're fine, okay? Because the body is like, oh wait, we were okay. Or it will stay like that because your dose is still too much for that patient, and you need to back off, right? Because now you've dropped them too low. And this is it is an art, okay? Because depending on how long I've been riding like this, if you drop me too quickly, my body is gonna go into overdrive because I'm not used to this, I'm used to this, right? It's like a person who works in chaos and then you take their chaos away and they're like, what do I do with my hands, okay? Same thing with this. So just be very careful and let your patient know what they're looking for. They don't know. All they know is you gave me this med and now I feel funny. And guess what they're gonna do? They're not gonna come back to you until you make them like their follow-up appointment. They're just gonna stop taking the med. And then you're gonna check up with them in a month and they're gonna be like, oh yeah, I stopped taking it. Why? That's when you find out. Instead of you telling them ahead of time like, hey, look out for this. If this happens, just give us a call and I can change your dose over the phone, or the nurse can come and talk to me or whatever, because you want that 1 month appointment to actually mean something. Not them coming back and they didn't have any medication in their system. Because now it's a pointless visit and you're being a cheerleader again, trying to get them back on their meds, okay? So, remember that. All right, when we're looking at our non-DHP calcium channel blockers, again, you have your verapamil, you have your DILT. When you're looking at your verapamil, it's not as effective, let me use that word, selective as when you're talking about your diltiazem, okay? So there is a preference of, like, if you're worried about selectivity, or if you're worried about like a patient who may be very sensitive and you're like, I just want to target this, like I just want to target the heart, like as much as I can. You're still gonna have some of that vasodilation occurring. So you see here, you're gonna have vasodilation no matter what, right? But if I'm trying to, depending on what their heart rate is, or what that vascular resistance look like, typically their heart rate, you're gonna say, I want more of a, if you wanna drop them low, let me give you an example. So let's say my heart rate is at like 100 versus somebody who's at like 150, okay? You can have more non-selectivity because you're gonna get a greater decrease. So in that person with 150, I'm wanting this med to drop me as much as I can, safely of course, but as much as I can, versus that person who may not need that much. Like they may just need a whiff of my calcium channel blocker, my non-DHP, to kind of help them get back into a range, okay? So you can play with this with the selectivity, and you can also play with this with the dose that you give the patient. Because you can always increase this dose. And you'll hear a lot of people say GDMT, which is the guided directed medical therapy. And so we'll say like, hey, here's this max dose. And you're not gonna start them at that max dose because you have to see what they can tolerate. And you're gonna play with their meds, because maybe you put me on these two and these two don't play well together. And now I need this, okay? So it'll be like a lot of you changing meds, but that's what the month visit is for. And then once you get them stable, then you're at 3 to 6 months and you're checking those labs, you're monitoring them. How's your potassium doing? Am I about to cause you to have an arrhythmia? Okay. So when you're looking at this, least selective, when we're talking about our verapamil, so you see you have more of a decrease in that cardiac output or the contractility, right? Because I'm not just focused like I'm going here. I'm targeting anything that I can to decrease. I'm non-selective as verapamil. So think about verapamil as being very free, okay? Just out there, floating around, trying to do some work, all right? And then when you look at this, you see that you have several different uses. We'll talk about more arrhythmias in some of our later lectures, but angina, so like that chest pain that some patients will feel, we use these for lots of different things, okay? And then looking at your DILT, you see that I'm getting some decrease, right, in that output that I was having, but just not as much as my verapamil, all right? And then you see that I'm still getting vasodilation in both of these. So this is, don't worry about like this so much. I want you to just say like, this is the words, but in the picture, okay? So like, less selective, meaning I'm gonna get a bigger bang for my buck with my contractility, and then they're all going to cause that vasodilation, but my non-DHPs, which are these top two, are not gonna have as much vasodilation as my DHP. Remember, my PEEMs are for my pressure. My verapamil and my DILT are more so looking at my contractility, my heart. So that's why you see these are very, you have more arrows, and then this one is like, maybe a little bit, but not really. Don't put somebody on a DHP and think that it's gonna do anything for your contractility. It doesn't really do anything. All right, so our clinical uses, we've gone over a lot of these. I told you when we're looking at picking between an ACE or an ARB, depends on that patient, right? We are gonna take their race into consideration, depending on who you talk to. Some people put more weight on it than not. And then also comorbidities. So asthma, diabetes, these things are very, very important for you to look at, because I can have that benefit if I pick my calcium channel blocker versus picking my ACE inhibitor. And then when we talk about diabetes, we'll look at like beta blockers. We don't love our beta blockers in our diabetic patients, and we'll go over that. So like when you're looking at this clinical use for this side, I wanna tell you to look at your calcium channel blocker so that you understand, because you're gonna compare your calcium channel blockers to your beta blockers. So how we compared our ACEs with our ARBs, we're gonna say calcium channel blockers, beta blockers, okay? Because now these two things, my calcium channel blocker and my beta blocker, are working on my heart more, especially my non-DHPs, whereas when I was dealing with my ACE and my ARB, it was like, oh, what's my vasodilation? Nothing with the heart, okay? So you're comparing your A's, and now we're gonna compare our calcium channel blocker with our beta blockers, all right? Looking at our uses, continuing to go, your isolated systolic hypertension, more effective in our patients who are African American. Again, still researching this. They're trying to figure out what they want to say about what is more effective when it comes to that. But again, it is a great medication. And then your caution in heart failure. So making sure that your patients who have heart failure, which we'll continue to talk about a lot of this stuff, but your patients who have heart failure, the one that we like to pick is gonna be our amlodipine. And that's very specific, so make sure you're looking at that, okay? So, if we have a person who has both of these disease states, right? So I have hypertension and I have had some type of, I'm in advanced heart failure. Stage won't really matter, but like, I'll tell you they have heart failure. Your one that you need to worry about, and not just think PEEM, remember amlodipine. They get an A+, okay? Amlodipine, 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 okay? All right, adverse effects. Depends on which ones you're talking about, if you're looking at your DHPs versus your non-DHPs. So when we're looking at our DHPs, remember that these are more so dealing with the vasculature system, right? So thinking about things that kind of deal with that, you're gonna see some more edema, headaches. Some patients will tell you that they're a little tired. Over time, this should resolve. The edema is something that's very important to watch out for, especially if that patient has heart failure, because if my heart is already working hard, you adding fluid is gonna make it work even harder, okay? And that's a big problem for me. So make sure that you're watching out for that edema and that it does go down. If they tell you that like, hey, like my ankles are swollen now all the time, we need to go ahead and switch them. Looking at your nifedipine, nifedipine can cause gingival enlargement. So think about like the gums just looking kind of like swollen. They look gross. There's no other word. I can't think of another word. But like they'll get really, really swollen, and that's just for your nifedipine. So we can say, the way I remember it is nifedipine is nasty to my mouth, because it'll make my gums big. And then looking at this high dose for your short acting. So when we talk about some of our medications, when you see something that is short acting, your patients are gonna have to take it more frequently. The chances of them actually sticking to the regimen to take it more frequently. Remember when we were talking about like our Cmax and our Cmin and trying to keep them into that target range, right? If I have to take something more often, I work. If I don't work, I nap. I go and I'm living my best life because I'm retired. I'm like probably not thinking about, okay, I need to take this every 8 hours, or I need to take this every 12 hours. So you're gonna see a lot of swings, right? The inconsistency in that can increase the risk of NMI, and then because they're short acting, they're hitting that action so fast that they can have vasodilation very rapidly, okay? So you're worried about adherence and just the sheer mechanism of that calcium channel blocker that you would be using. I'm not going to make you remember what's short acting and what's long acting. Just remember that this is a adverse effect that could occur if you use a short acting calcium channel blocker. And if it comes up, it will say short acting calcium channel blocker. We are not going through all of that, it's too much, okay? And then looking at your non-DHP, when you talk about our verapamil, just cause constipation. So it makes you very uncomfortable, okay? Constipation is a big one that you'll see with your verapamil. Try to make sure that they're drinking a lot of water, and then understand that with your verapamil, because it was very free, right? You're gonna see more, a potential to see more bradycardia, right? Because it's gonna decrease that heart rate more than my DILP was. So that's why you see the arrow going towards your verapamil. And then my interactions is gonna be one that you can sometimes see in a lot of these conditions that we're gonna talk about this block, the digoxin. Digoxin is also a medication that's gonna be working on the heart. So you'll see with digoxin that it can increase the levels. 20 to 30% is a lot for digoxin because it is a narrow therapeutic index drug, okay? So it doesn't seem to be like that big of a deal, but a 20 to 30% increase in DIG is a huge deal, and we're gonna talk about digoxin. It is a question that they love to ask on exams for some reason, not just our exams, but like your PANCE exam. Even though it's an old drug that we don't love to use, it's one of those reserve drugs that like works. We don't like to use it because it causes more work for us. You have to do monitoring of it because of the narrow therapeutic index, okay? But it's a great, great drug. And then your beta blockers with one of your non-DHPs, because again, they're both gonna be dropping, right? That negative inotropic, they're both gonna be dropping that heart rate. So then you can experience a lot of bradycardia. Your patients will tell you about the dizziness, the headache, the tiredness, because you're adding now two things that are lowering. So remember I told you your calcium channel blockers, your beta blockers are the two things that you're comparing together. When you see your dihydropyridine calcium channel blockers, I'm not worried about that, right? Because my effect on my heart, it was minimal, okay? So remembering your calcium channel blockers, which one is a DHP versus your non-DHP, all right? Let's take a break and come back. I had some questions, and I'm also gonna ask this question again, because I asked about, so guidelines are always gonna change, right? And they continue to change. And what we do in real world practice, and what we do when we're looking at like teaching you guys in here is sometimes a little different, right? And so, in practice, you're gonna have people who have been practicing for longer than you've been alive. And they're gonna be like, I don't care what the guidelines say, this is what I'm gonna do. And they're gonna like hang on to that, right? Your job is to do what you are comfortable with your license. Your other job is going to be to stay on top of guidelines because they change all the time. So that's why we have CEs, continuing education, so that we can stay like on top of all the new information. When I The guidelines have just come out again. I haven't even seen the new guidelines that just came out because I've been working on the slides for here and for there, right? So I haven't even seen them yet. I asked this question last semester because it was like, what do? Do we teach what just came out that could potentially change again by the time y'all take the pants? Like, just what I want you to remember is this stuff is ever changing, okay? New research is gonna come out, new drugs are gonna come out, and sometimes when new drugs come out, we're like, oh, this is great. And then your people are gonna see commercials, and that's all they're gonna want from you, is that new drug, okay? So like, understand that this is your baseline, so to speak, that we're giving. And then I'm gonna also clarify with them on what you guys can expect on your pants as far as like the guidelines will go. Okay, because I don't know how far the delay is in when they update your exam from when a guideline comes out. There's usually like a period in between. I've heard 2 years, I've heard 3 years, I've heard they don't ask you questions that are guideline directed because the guidelines always change, which then means they have to keep writing questions like quicker. So I will try to find that out to see what that looks like for the validity or like how you would use this in regards to the pants. But for our exam, we're using these slides, okay? So don't confuse anything with the new guidelines. But a big thing with the new guidelines that we were just talking about was the stage 1 that they're not using the ASCVD risk calculator anymore. They're like, if you have hypertension after they get the several readings that they need to diagnose someone with hypertension, they're just gonna put them on a bed, they're not gonna do a lifestyle. So that was one of the bigger things. And then talking about the race, I don't know if y'all can tell, but I was kind of like rolling my eyes a little bit while I was talking about it because it is very back and forth, and you're gonna see a lot of African Americans who are gonna be on these meds. It's not really a preference. We'll put somebody on an ACE and see if they have side effects. Like they're great meds, they work. Okay, so I just don't want you to be like African American are like, I don't want you to do that. African American calcium channel blocker, like I don't want your brain to think like that. Okay, it is a thing that continues to like sway. All right, I want you to be aware of it. And if I ask you an exam question on it, I will be very like clear in where I'm wanting you to go with this, okay? I will try to make an example of that. All right, so now looking at our adrenergic system blockers. Everything else that we talked about were a part of us talking about our backbone that we discussed, right? These are things that we are using to kind of help control symptoms that your patients may be experiencing that aren't controlled by our backbone. But you always have to get everybody on those backbone meds first. You're not gonna be like, oh, I'm just gonna put you on a beta blocker just because that's what you feel like doing, right? Like they need to be on that backbone, and then if you've maxed out their doses on that backbone, then you're like, okay, let me add these. Also, if there's a reason why I can't take like my calcium channel blocker, then you can see some people sometimes on some of these meds that we're gonna talk about that are adrenergic system blockers, okay? So you're gonna try to put your patient on your backbone unless there is some reason as to why they can't be, then these are like some of our other meds that we're gonna talk about, okay? So backbone, and then you'll start on doses that are like low. So we say start low, go slow, okay? You'll put them on that. Now, if their blood pressure is really out of whack, you don't need to start at the lowest dose. You know that you gotta kind of hit them a little bit, okay? But you don't wanna hit them too hard. So that's where it's gonna use your clinical judgment. We're not gonna talk about doses. I'm not grading you on doses or expecting for you to know them. But just understand that like you start them low and then you continue to increase their dose until they get to your target dose. All of these have target doses, all of these drugs, okay? And we get them there, and that is what should maintain their hypertension for them. All right, so looking at this, your alpha-1 adrenergic blocking agents, in the name, again, you have a great hint. So they're blocking the alpha-1 receptors, and therefore we don't have the vasoconstriction, and that means that we're gonna see a decrease in our blood pressure. You also see that we have a decrease in that vascular resistance, right? Because I don't have the vasoconstriction. So anytime you see vasoconstriction, just equate that to our TPR, equate that to that vasculature being resistant, okay? My water hose is closing. I don't want my water hose to close, I want it to open in my patients who have hypertension. And then looking at your clinical use, you see that it's not something that we're gonna typically see as one of our first line agents. Our first line agents are gonna be our backbones that we talked about. And then looking at using these as monotherapy, not something that we would typically see. We'll typically see our monotherapy in our patients who are gonna be on one of our backbone meds that we already talked about, okay? So these, again, just put, if you wanna put right here, like second line or something, all of these are kind of like downstream, okay? Everything that we're gonna talk about this hour is downstream. So very rarely used. We'll see this in some of our patients who have BPH. We'll use this. We'll talk about BPH later on in the semester. Hypertension, and then you have your patients who they'll be taking like their beta blockers, and they are still not controlled. They'll take their ACE inhibitor. They're still not going to be controlled. We can add this on here, and that hopefully controls them, because remember we said that whenever we put them on 3 different meds and they're at their maximum dose and we're still not getting the response, that those are our resistant patients. So sometimes like this is like that 4th thing that we're adding. Sometimes it'll get added on as the 3rd thing, but usually this is like our 4th agent that we're adding on because that patient is not responding to anything else, and we're trying to see if this will be that one thing that kind of tips them over the edge to get their blood pressure to lower. I don't think you would be seeing those patients. They'll probably be going to a specialist at that point, because that means that there's something like some underlying stuff going on. Typically, you'll be dealing with like your stage 1 and your stage 2 most of the time. All right, here are your agents that you see. So your prazosin, you can also use the prazosin, and we use this a lot, and I see it a lot for patients who have PTSD. So remember your P with your P for PTSD. It's a very good medication, very good when we're talking about our BPH, so you can kind of remember that also. P, right? So when we talk about BPH, it affects their ability to sometimes urinate. We'll go into BPH later, so just try to remember that together. BPH, prazosin, PTSD. Okay, we can also use it for our patients who have hypertension. More specifically in uroselective, we have our tamsulosin and our sildosin. And then when we're looking at these two, they're very, very effective at targeting our symptoms that our patients have with BPH. Tamsulosin is the one that you're probably going to see used the most for this. So very good medication. It's a cheap medication, and it's very, very good at controlling their BPH. Not so much that you're going to see this used, well, not at all. You will see this used, though either of those used for hypertension. Adverse effects, orthostatic hypotension, okay? So it's going to vasodilate to where some of those patients will, whenever they're laying down and they get up, they'll feel like very, very dizzy. Some people will pass out. So you need to make sure that they're getting up slowly. So you'll tell them, okay, I'm going to sit up very slowly, and then I'm going to try to stand up, and like make sure they're standing near something, especially if they're elderly, because you know when older people fall, sometimes it's like downhill from there when they break like the hip or something. Okay, so we don't want to be trying to control their blood pressure, and now we have like a fracture or something more serious occurring for them. You're going to see this more so with that first dose. After that, it typically goes away. So just again, give them that counseling point of, hey, when you take this, make sure that you're sitting down, that you're not going to be driving anytime soon. If they have someone who's around, just make sure that that person is aware. It's not anything that will like kill them. It's just going to make them very dizzy, okay? And it will go away. Tachycardia, that's reflex, okay? So again, because it's going to drop things, it'll kind of have that reflex to where it'll go back up. But that eventually also subsides. Your edema, headache, drowsiness, weakness, things like that we'll typically see in a lot of these medications that we're talking about. Nasal congestion and the inhibition of ejaculation. The inhibition of ejaculation is something that you definitely need to tell your males, okay? Reason being is that if something typically happens that now doesn't happen after I have sex, I'm gonna freak out. And if this is the only thing that you gave me, now this is all of a sudden happening, I'm not taking my med, okay? So make sure that they understand that like they may not see, like the ejaculate come out. Okay, so that's kind of what that means, and sometimes you'll see where it's retrograde, where like it happens, but it just kind of goes back into the body and it's not coming out, or it's a lesser amount than what they typically have. So just let them know that is a possibility, because that can be scary, okay? All right. I know it's small on the slide, but it's a big deal. Your alpha-2 agonist, we're looking at this, the biggest one that you'll see is gonna be your methyl dopa. Mechanism of action is listed there, so just understand that we're just stimulating those receptors, and kind of using that negative feedback system, to our advantage, okay? So we're inhibiting that sympathetic outflow, which we talked about already with the sympathetic outflow. That's what's causing that constriction, right? Now I've clamped down, fight or flight, I'm ready to go. So we're inhibiting that when we're looking at our alpha-2. Clinical use, you'll see this in our urgency and during pregnancy with, remember this is a part of our lifetime movie network, our drugs. So if I had to take my patient off of their ACE, their ARB that they were taking, and I was like, oh, I need to put you on something else because you're pregnant, this is one of our ones that we have as an option. Adverse effects, because it's dealing with that central acting adrenergic system, we'll see some anticholinergic effects. So when we think about anticholinergics, remember from last semester, they kind of dry things up, right? So dry mouth, constipation, some people will feel sedated. So just think about drying things up, sucking life out of it, okay? And then your hypotension, again, same thing like what we just saw before with our alpha-1. And then the impaired mental concentration. So this isn't something that's very common that we see, but it is a possibility. So just think about like potential nightmares and things that you could, your patient could have. So just think of like CNS disturbances is an easy way to kind of remember all three or four, however many of these things. Okay, so the longer that they're on it, the more likely you are to see these things occur because they are centrally acting. So that's why you're seeing CNS effects, because it is centrally acting. Okay. All right, your adrenergic antagonists. So we have different types of beta blockers, so to speak, that you have. When you look at these, you see that these all end in LOL, law. Okay. Remember that for your beta blockers, another word for a beta blocker is the adrenergic antagonist, okay? So you have your non-selective, selective, mixed, and non-selective, and then your intrinsic or sympathomimetic activity or ISA beta blockers. So a way that I try to remember this is that when you are looking at your beta 1 selective, I try to think of this as like A through N or A through M. And then my non-selective is N through Z. I'm not gonna make up drugs for you. I'm gonna give you real drugs, but if you have to figure out like what's selective versus what's non-selective, that's how I try to remember it. Like all of these start like A through M, except for you. And then these are everything at the end of the alphabet for your non-selective, okay? And then the thing with this is that your propranolol, you see how it's in both of, like it has activity in both of these sites, non-selective and selective. And then your mixed, I think about mixing paint in the lab for my car, right? So you have your labetalol and your carvedilol. Those are your mixed actions. Okay, and then my ISAs, ACE PIN. So you have your ACE butylol, pendolol, and then your penbutylol. ACE PIN are your ISAs. Okay, so these are several different ways that we can classify our beta blockers. Okay, so I could just ask you a question and be like, which one of the following is an ISA? Which one of the following is mixed? Okay, and then you would tell me which one it is. alright? Looking at, again, our beta blockers, I told you that's what we typically call it. You don't really hear people saying beta adrenergic blocking agents, because that's a lot. We just say beta blockers. Sometimes you will see this abbreviated as BB in some people's notes as well. So essentially what this is doing, it is antagonizing exactly what it says, my beta receptors, okay? I'm blocking that from happening. So when we talk about beta 1, we have beta 1 in our heart, and 2 is where? In our lungs, right? So when we're looking at this, I'm focusing on the heart, right? So I'm blocking those receptors that are mainly located on the heart, and therefore I decrease my cardiac output, right? So if I can decrease my cardiac output, I am decreasing my blood pressure, okay? So that's what these are doing. This is also very good at stopping that sympathetic outflow. So you'll see like a lot of people who get very nervous on their exams, they're in fight or flight mode. You'll sometimes see that they're on the beta blocker, kind of help them calm down, okay? So that they don't beat up their exam, right? And then our clinical outcome, you see that they're pretty good at decreasing that blood pressure. So I don't need you to remember these numbers, just understand we're using them to decrease our blood pressure, okay? Looking at our clinical use, several. We love beta blockers. We're going to talk about them a lot. We're going to talk about them when we talk about asthma. They're just in a different way, and we're blocking beta 2. So we're going to talk about this a lot. But when we're looking at this, you have angina, so we're going to see this. These are going to come up in almost every lecture that we have for the rest of this block and some of our next one, okay? So angina, arrhythmias, CHF, MIs, like these are very, very cheap medications. They're old medications. They're good medications. When we're talking about hyperthyroidism, essentially with this, we're using them for the symptoms that some patients will experience with hyperthyroidism. Because hyperthyroidism, everything is kind of like sped up, and so they'll experience a lot of tachycardia. And so we use these to kind of slow their heart rate down. It's not fixing their issue with their thyroid, it's just calming down that heart. So when we think about these, think about the heart. Beta 1 for that one heart, all right? And then our migraine headaches, you'll see propranolol used quite a bit for that. Somewhat effective, depends on who you talk to, but it's a very good medication for you to use prophylactically, so before they even start to experience the headache. So if someone has several migraines, which we'll go over this, but if they have several migraines, you can start to give them prophylactic treatment so that they can prevent the migraines from even happening. And because this is a low threat medication, they'll just take this every day to prevent those migraines from occurring. Gotta watch their blood pressure, okay? Because even though they're using it for that, even though I'm not using it particularly for my heart or my blood pressure, I still need to monitor what their heart rate is doing, what symptoms they could be having, because they could still have adverse effects from the beta blocker. All right, so we already talked about where these receptors are located. 1 in the heart, 2 is in lots of places, but when we start to focus on it, we're going to talk about them a lot when we're dealing with like our lungs. But I want you to focus right now on 1 because that's what we're looking at. When you're looking at that cardioselective, you see that those are going to be more so targeted at my beta 1 versus dealing with my beta 2, right? Because I'm selective, I am zoned in, I want that one heart. Like that's all I want, okay? I'm not worried about the lungs, I'll get you later. I am selective, I am focused on that. So that's where you see that, the cardioselectivity, okay? When we look at our patients who are taking these, just understand that some of them are, we'll deal with that. I think it's on a later slide. I don't want to talk about it. Intrinsic sympathomimetic activity. So this was our ACE pins, right? So when we're looking at this, just understand that it's still blocking, but it also has some agonistic effects to it as well, okay? So that's what your ISAs are doing. They're partial agonists. So they're kind of like imposters. Like they're in our antagonist group, but like they're also kind of working for the other team, okay? And then those are our medications that we talked about. So ace-butylol, pendolol, and then your penbutylol. And then understanding that your pendolol has greater ISA than your ACE, okay? So ISAs are like our imposters. They have some agonistic effect as well. They're not just blocking, okay? Everybody else is just blocking. And then this is just showing you kind of what it looks like. This is just a picture, so y'all can FYI this. Just understanding like, hey, this is what's occurring, this is how they're binding. I don't need y'all to focus on that. All right, now looking at the fact of this lipophilicity last semester thing, freshman semester thing, right? When you see anything that is lipophilic, just understand that you are going to have more CNS effects because it's going to be able to cross that blood-brain barrier, okay? So a lot of your side effects that you will experience are going to be the drowsiness, those nightmares, all of that confusion and stuff. So usually whenever I see anything that says central or like CNS or lipophilic, I'm like, okay, nightmare, like pop those side effects into your brain. Okay, because these are the ones that you're gonna always see when we're talking about that lipophilicity. So that's what you see here, all right? You're gonna see more of the drowsiness. When you're looking at the ones who have the low lipid solubility, they're gonna have a better CNS profile because they're not gonna cross as much, right? So I'm not gonna affect my CNS as much. I'm not gonna see as much of that drowsiness. When you're looking at your solubility, just look at these. Please remember the difference between which ones have the low and which ones have the high. Because if I'm worried about a patient who is saying like, hey, I have to go to work and I'm very sensitive to medications, because you're gonna have some patients who are super sensitive to meds. I'm very sensitive to medication, and I'm very worried. Well, let's steer clear of my propranolol or my bisoprolol, right? Because I'm likely to have more of those CNS effects. I'm likely to have more of that drowsiness. Hey, I work and like I don't wanna deal with that, right? So boom. But I will say this, there's a lot of people on propranolol who are not walking around with CNS effects, okay? So if you want to try it, and depending on what you're using it for, if you specifically need to use your propranolol, then you can and say, hey, if this causes you to experience a lot of drowsiness, then please contact me and let me know and I'll switch you. And then you switch them to, and that's real world. Exam world, just remember which one is low and which one is high, okay? Don't use your high in a patient who is telling you that they don't want to be drowsy, okay? All right, precautions and cautions. So a lot of patients are gonna have comorbidities, right? A lot of patients are gonna have asthma, a lot of patients are gonna have diabetes because we are just such a healthy nation. When we're looking at our sexual dysfunction and drug withdrawal, sexual dysfunction is one of the biggest reasons why patients come into the pharmacy and they will tell me that they do not take their meds because nobody told them about sexual dysfunction, right? Even if you're putting a patient on this for migraines, even if you're putting a patient on this for like some of the anxiety that they're experiencing, you need to tell them this, okay? Some patients still want to have sex even though they're nervous, okay? So you need to let them know that. When we're looking at our diabetes, this is very serious because hypoglycemia, which is low blood sugar, is just as bad as hyperglycemia, which is high, okay? So when somebody gets very low, like essentially just think about you're like turning off a car and they can die, okay? So when we look at this, you'll see that some of the symptoms are masked or blunted by someone who is taking a beta blocker. So they don't know, like typically a diabetic, they will know, bless you, like that they're experiencing hypoglycemia. So they'll eat like a snack, they have all these little things that they can do, but in this situation, if they're on the beta blocker, they don't even know, okay? So they miss their early warning signs, their numbers continue to drop, and then they end up in, sometimes it can be a coma, sometimes they can die, okay? So very important for a patient who has diabetes to continue to monitor or check their glucose levels to make sure that they're where they're supposed to be. We're not as worried about this anymore as more people start to get CGMs or continuous glucose monitors because their phone or whatever is gonna, the machine will beep whenever they drop very low, just like it's gonna do it whenever they're very high, right? So like this then doesn't become such a concern, but a lot of people still don't want to use CGMs yet. So this is an important counseling point if you have somebody who has diabetes to let them know that their glucose levels may start to fluctuate and their hypoglycemia symptoms that they typically feel may be masked. asthma, when you're looking at this, patients who have asthma, they have bronchoconstriction. If they're taking a beta blocker, that can also cause bronchoconstriction, right? Especially if it's non-selective, because I'm not looking for beta 1, I can also hit your beta 2, right? So it can worsen asthma in my patients if I choose a non-selective beta blocker. Because I'm now targeting beta 1 and beta 2, so I'm hitting your heart and your lungs. So in that situation, I would want to try to find something that was more selective so that my patient who has asthma isn't affected. Sometimes, depending on how bad their asthma is, we may not even use a beta blocker. But for this, just understand that if I have asthma, a non-selective beta blocker is a big no-no because I can cause bronchoconstriction, they can have an asthma attack. Okay? Sexual dysfunction, ED, decreased libido, like they're just not happy. And then your drug withdrawal, understanding that if you just stop it because of the mechanism of how it's working and now not having that beta blocking occur anymore and you just pull them off, now it's unopposed, that action that we have, and it comes back in, like we had it suppressed. And then if I just stop my medication and then my receptors are now starting to get activated again, that's where you can see where some people can have like that chest pain, the angina, MI, they can die. It can be a big deal. So we typically will taper off of these medications for that reason. Looking at our interactions, did I skip one? No. Looking at our interactions, if you have a beta agonist while you're using a beta blocker, we got a net effect of nothing happening, right? So they're just competing with each other to see who gets there first. Am I gonna activate this beta receptor or am I gonna block this receptor? So now they're like canceling each other out, so what are we treating? So that's why we don't use them together. Pick one, try to treat them. Your calcium channel blockers, remember if I use a beta blocker with a calcium channel blocker, they're both decreasing my heart rate. On both of those, I'm decreasing my cardiac output. So if I use both of them together, now I have a bigger decrease, more likely to see bradycardia in those patients. So if you did want to do that, that's why we were talking about specifically the non-DHPs are a problem. If we were going to use that DHP, you're not going to really see that, right? Because those are dealing more with our vasculature, okay? Looking at your NSAIDs, just looking at the fact that it may impair those hypotensive effects that you would see with your beta blocker. So we watch out for our NSAIDs, and then clonidine. This is another controversial thing because why wouldn't it be? When we're looking at this, you could potentially cause a hypertensive crisis in a patient if you stop your clonidine before the beta blocker, and this just has to do with the way that both of these medications work, right? So if you are suppressing the body's normal system, regulating system, and then you yank one before the other, you have unopposed now regulation. So sometimes you'll get more alpha activity or you get more beta activity, which then leads to the effects of alpha activation or that beta activation, depending on which one. So that's why you're trying to taper off that clonidine, so you don't just pull it off, you'll taper it off, stop it first, and then you would do the beta blocker. Again, this is a controversy thing. Some people believe it, some people don't believe it, and they do it. So you will see this done. I have seen it done. The person didn't die, they were fine, they didn't die though. So it depends. There's lots of articles about it, but textbook wise, they say to stop the clonidine before. All right, when we're looking at our mixed, you have your alpha blocker and non-selective beta blocker activity. So essentially just in the name of what we're talking about. So when we're looking at our effects in hypertension, which is what we're focusing on right now, just think about the fact that it's going to decrease the cardiac output in our without that vasoconstriction occurring, okay? So these are good medications. Just make sure that you're looking at the entire patient, okay? Because I'm a non-selective beta blocker as well. So in my asthma patient, this could be something that could be a potential problem, right? So like, make sure that you're looking at, your patient as a whole when you're looking at a real person and when you're looking at your exam people, okay? Adverse effects, bradycardia, especially if that dose is too high. Watching out again for your patients who are diabetics, because we could be masking, that hypoglycemia, the bronchoconstriction in our asthma patients. Hypotension can happen with any of these medications, right? The higher the dose, the more likely we are to see that occur. And then our interactions that you have, just looking at this, like if I'm giving an alpha agonist or a beta agonist with something that I have that's blocking, again, that net effect, they're canceling each other out because this is an alpha and beta blocker. Now if I give an alpha and a beta agonist, I'm opposing what my med is there to do. And then the additive effect, if you add on another antagonist, right, because they're also blocking, an antagonist is blocking. So now I've added two things that are blocking the same exact thing. I'm expecting to see that additive effect. And then you see the cumulative negative inotropic effect, or essentially the way to say that is the chance of them having exaggerated bradycardia is if I gave a non-DHP with this as well, right? Because I'm still blocking that beta activity. Okay, so that I can drastically drop their heart rate as well with this. All right. Looking at a mixed, again, we had our carvedilol, right? I mixed my paint in a lab from a car. That's how I remember it. So your carvedilol, you see you're using it, hypertension, congestive heart failure, which we're gonna talk about. And then your dosing, the only thing that I wanna make sure that you know with this is that they're gonna take it with food, because remember we said that hypotension was one of those possibilities that they could experience, that orthostatic hypotension. We're gonna tell them to take it with food, and we're also gonna tell them to make sure that they get up slowly, okay? If they're in a lying position, they sit up, they stay seated, give their body about a minute or so. Some people say 5 minutes, but I know people don't realistically do that. But give their body a minute or so to kind of readjust to the fact that now they're in a different position, and then tell them to stand up and make sure they have something to kind of steady themselves, okay? But food kind of helps decrease that hypotension that they typically will experience. And then looking at your labetalol, the big thing for you to notice here is that we have that one in an injection form as well. So if we have something where there is a severe hypertensive situation and I need to get their blood pressure down quickly, I have a route for me to give them that medication IV. Okay, so that's what you see your labetalol for. And then remember, this one is a part of our lifetime network. All right, direct arterial vasodilator. We have hydralazine. So this medication is one that is, it's an older med. We do still see it used, not as frequently as I used to, but it is still used. Just think about this as like something that is just decreasing that blood pressure, decreasing the resistance that we have, and that's how it helps contribute to lowering the blood pressure. Our clinical use, typically we see this with our isosorbide, and it comes as one pill called Bidil, and they can take it, and it's again a combo, and we love combos when we're talking about hypertension and our adherence with our patients. So this is very good for African American patients as well. I see it in patients who are also not African American, but this is good to help with the vasodilation for them as well, which is what that isosorbide is doing. Isosorbide is good for vasodilating. Off-label, again, for our hypertensive emergencies, you'll see this used in preeclampsia where patients are pregnant and they're experiencing high blood pressure. Sometimes you can see this occur. If they have a history of it, they're more likely to have it happen again. So just a FYI for that. And then adjunct to your tachycardia that some people experience in pregnancy. I'm not gonna ask y'all about this because this is very nuanced and this is like a specialty type of thing. When we start talking about this, I just want you to remember your lifetime movie network when we're talking about our pregnant patients, okay? Like that's what I want you to focus on. Just understand preeclampsia and hypertensive emergency, but Biden, okay? This is looking at The response to some vasodilators that are occurring whenever we're using beta blockers is just a picture of kind of what we've already discussed. So if you wanna see more words of like how it's blocking that sympathetic outflow, and then ultimately what ends up happening is you're gonna have the decrease over time with that heart rate and the blood pressure and everything kind of starts to go down. You'll definitely, in patients who are symptomatic, see a dramatic response quickly, especially if they're having issues like tachycardia. You'll see that go down very quickly. So with this, you can just FYI this. All right, our direct arterial vasodilator. So used concurrently to reduce that cardio stimulation. So to decrease their heart rate is essentially what it is saying. And then when we talk about our diuretics, we already talked about diuresing our patients, right? So that's for us to get fluids off. We don't want to keep those fluids on. It's gonna make their heart work harder. And this is very, very important in our patients who have CHF or any type of heart issues, right? Because now you're making my heart work a lot harder. Adverse effects, you see that increased renin, which means that therefore I'm going to retain. I'm gonna retain sodium, I'm gonna retain water, so then that's when we'll start to see the edema, like the pitting edema that we were worried about, okay? So in that situation, that's how you know, like, hey, the patient either can't tolerate it or my dose is too high. So then you start to change that dose. And then everything else down here is pretty much like what we've been seeing with a lot of our other medications, headaches, tachycardia, basic kinds of things. One to let your patients know about is sweating, and they may also have flushing. If they are a lighter complexion, sometimes they will turn red like the first 30 minutes to an hour of them taking the medication, or feel like hot, which is where the sweating kind of comes from, because they've opened everything up. We vasodilated, and now just think about everything like going through a lot faster, okay? So some patients will experience this. This is one of the big ones that they do experience, like side effect wise. All right. Our treatment of hypertension. So we're gonna say they have stage 1 or stage 2. I'm gonna see if I'm telling you that on the exam or not. I don't know if I want to tell y'all that. I'll let you know, or if I want you to remember those numbers. But stage 1, stage 2, this is exactly what we talked about before, already remembering that our stage 2, we needed to make sure that they were on 2 meds. The other thing with this that we were looking at is that you're gonna have to get several readings before you diagnose them. 1 reading is not enough. So you need at least 2 of those readings to be confirmed before you're saying, hey, this person has hypertension. I had a preceptor who would also make them on that second visit when they come back, bring their home blood pressure cuff, and he would take their blood pressure, wait 5 minutes, and then take it again to see if his read the same as theirs, to see if it was calibrated, if it was working properly. And then he would have them go home, take their blood pressure, and email him to say like, hey, here are what my readings are, to make sure they didn't have white coat, and that's why their blood pressure was high, okay? So like, he's definitely making sure before he just sticks them on a medication that they have hypertension. Do your due diligence, don't just throw them on a medication. Sometimes though, people really do need it. And then remember here, when we're seeing the difference between and then looking here where it says or. So it doesn't mean that both have to be elevated, right? I can have one or the other elevated when I'm talking about my stage 1 and my stage 2, okay? Looking at our goals, this very much so depends on what guidelines you're looking at. But everybody is in agreement with the fact that we should be below 130/80. Pre-hypertensive stage is anything that's over that 120/80. And so you have different providers who will do different things and start people on meds depending on what their comorbidities are sooner rather than later. And this is kind of what we were talking about with, am I gonna tell my patient lifestyle modifications, or am I gonna put them on a medication? This was what we were just talking about with the new guidelines. So I will get back to you all on that to make sure, but for our testing purposes, like in this class on the 15th, we're gonna stick with what is on these slides, okay? And then I'll get with them to tell y'all and update you on what they say about the PANS. So for this, what I need you to understand from here is that our goal is less than 130/80. Nice words, that we don't need less than 130/80, just highlight that, okay? So our CBD risk calculator is what we already talked to you about. What I want you to look at here and pay attention to is your non-modifiable versus your modifiable, okay? Non-modifiable are things like, this is it, I'm stuck with it, I was born like this is who I am, right? Versus my modifiable are things that I can kind of control. Some of this stuff is genetic, right? Like you have some people who genetically are predisposed to have high cholesterol. They're not doing anything wrong, that's just how their genes are, right? But think about your modifiable as like me eating McDonald's all day, kind of thing, okay? And drinking smoothies and living my best life, and I don't care about my blood pressure. Think about all of that as modifiable, and I smoke cigarettes. And then my non-modifiable is like, this is how I arrived, okay? So those are your 3 non-modifiable and your modifiable. That's all I need you to know from this. When we talk about statins, we're going to learn a lot about our ASCVD risk calculator. So we're looking at it here briefly so that you can kind of know about it, and we talked about it at the very beginning when we looked at this, right? So this is that same exact chart that you saw from before, just knowing that we're looking at it in our stage 1. We talked about just now the guidelines being updated to where like typically they're not gonna look at this, they're just gonna treat it aggressively to say I need you on some meds, all right? But for our testing purposes, we are saying, hey, stage 1, if their ASCVD risk score is less than 10, that we can do those non-lifestyle modifications, okay? So we already saw this chart, we went over this chart, I think we're good on this chart. Our non-pharm, I'm not gonna ask you about non-pharm because I care about drugs, okay? Tell them to be healthy, tell them to eat right, tell them to exercise, refer them to nutrition, okay? Smile at them, be patient with them because this is going to be hard for you. It's hard for the patient, but it's harder for you because you have the knowledge and you know what they should do, and they're gonna keep coming back to you and telling you that they're not doing it, okay? So you're going to have to be very sympathetic and empathetic with your patients because this is something that is very hard to manage, especially if they don't have symptoms. They're gonna look at you and be like, Pa, I'm not taking that medicine. And you're gonna be like, Pa, you're gonna have a stroke. Don't say that. Okay, but make sure that you are stressing and you're just be patient. The kinder, and sometimes like my preceptor, he told the person, he's like, if you come back here the next time and your blood pressure looks like this, I'm discharging you as my patient. If you don't care, I don't care. And I was like, sir, you cannot say that. He was like, he's been coming here for 2 years. And he still brings me his food log with Burger King. And my preceptor was like a guy who worked out all the time. He was not having it. And he did. The guy came back and his blood pressure was still high and he discharged him. And I was like, oh, you were serious? He was like, yes, because I'm gonna get fired the next time I talk to him because I have no patience anymore. All right, so try to have patience, take care of it. You're like, no, take care of your patients, try to have patience, okay? But understand, like, this is a lot of life, like, they're having to change their life, okay? From doing something that may be historically done around them. It could be genetics that are causing them to be in this position. It is very, very difficult. You have some people who work out, who eat right, and they're still gonna be in this position. Same thing with cholesterol, we see that. So just be patient and try to help them get to their goals. Don't just discharge them, okay? But after 2 years, I could understand. This is what we were also just talking about, right? Like the physical activity, making sure they're moving around, making sure that they're eating right. Try to limit or stop all the way alcohol, because that increases your blood pressure as well. The other thing, if you need somebody to go to nutrition, you can talk to them about it, but you can also refer them to nutrition to help them. Okay, nutrition is your friend, and it's a referral, and that way they're not in front of your face for you to tell them what to eat, right? You can start them off until they get to nutrition, but you're not gonna have time to keep like following. It is a very big deal to change what you eat. Okay? Looking at our treatment, we already talked about this. So we talked about our backbone. That's what you see listed here with our first line, okay? And then we have all of the different things that we can choose from. Make sure that you're looking at your patient, right? Real patient, exam patient, we're looking at them top to bottom. What is making me not be able to give this medication? Okay? Is there a preference? Yes, if I'm telling you that there's a contraindication, if I'm telling you that they're on another med that they can't have that interacts with one of those meds on your backbone, right? That's when you're picking one over the other. Other than that, pick whichever one you want. Okay? But it's never really gonna be that easy, not even in real life, okay? You're usually gonna have to look at something and be like, what else is going on here? What other disease state does this person have, right? Because people are gonna come to you with several things broken. And then looking at my treatment needs to be individualized. This is why I'm telling you to look at the patient. You can't be like, oh, you have hypertension, you get this. You get labetalol, you get labetalol, you get like you can't do that. You get hydrochlorothiazide. We're not Oprah, right? You have to look at me and say, hey, what do I need? What do you need to treat me? What else am I on? What other, what history do I have? What contraindications do I have? Okay? Because we're not all gonna fit into that one box. You can say, all right, here is my little toolbox that I have for this disease state. What do I need to pick out for that person? Okay? And then looking at your age, be realistic when we get to our older patients, right, with their goals. Like if I'm 80 something, let me chill and like live the rest of my life. Don't let me die with high blood pressure, right? But like think about realistic goals, because, and I'm saying that, and we'll talk about this when we talk about diabetes, but sometimes if we set very stringent goals, they can't reach them and some people will give up, right? So if I'm already high and you put your like, yes, we want everybody to be like less than that 130 that we talked about already, right? That's what we want. We want everybody to be it. But sometimes we have to slowly get them there. And then if I'm older, I'm set in my ways. Yes, you want me to do that diet? I got it. Not doing it. When Raina is old, she's probably not gonna listen, okay? But just make sure that you are saying, yes, you still have this goal. Yes, we're trying to get you there. We're just gonna try to get them there a little bit. Like, be more patient because it's more difficult. Pay attention to that hypotension that our elderly patients may tell you about because they're already older, right? So we need to make sure that they don't fall. When they fall, they break their hip. We have now caused a lot more problems, okay? So make sure that you're trying to treat to their tolerance because we may hit a point to where we can't drop them any lower, all right? We can't increase that dose anymore because they're experiencing those side effects at a lower dose, all right? And then we'll finish this up tomorrow. We'll start here. Have a good day.